You've asked me to talk about the Westminster view of NHS reform. And if I may, I'd like to begin to set the context by repeating something that I've said many times over the last 12 months, which is that there are in truth two parallel processes of reform going on in the National Health Service, one of which is unprecedented. It's never happened before, either here or anywhere else, and the other of which I think most people in this room would regard as all too precedented. Let me begin with the one that I certainly, and I suspect most of you, will regard as all too precedented, because I don't propose to spend very long on it. And that is the process of change of the management structures that is the result of the Health and Social Care Bill going through Parliament. The process in the Health and Social Care Bill is a process of change of the management structures. I don't have, as I was saying, any problem with it as a policy, because I think in truth it is, broadly speaking, the same policy as was first legislated when I was first a junior health minister 21 years ago, when Ken Clarke legislated the reforms of 1990. It was then that the principle of what we used to call purchaser-provider, what we now call commissioner-provider, was first introduced into the National Health Service. There was huge controversy at the time about the principle of purchaser-commissioner-provider, huge controversy about the principle of what was then called NHS trusts. We had a huge argument about whether this constituted the privatization of the National Health Service. Was there any role for competition in the National Health Service? These are all hugely familiar, very well-rehearsed arguments. They were rehearsed in 1990, and in case anyone missed it, they were rehearsed again in 2002, when this time it wasn't a Tory government, but it was a Labour government under Alan Milburn as Secretary of State that legislated, broadly speaking, the same policy prescription all over again. We now, at that time, we learnt to call purchasing commissioning, we learnt to call NHS trusts foundation trusts, but broadly speaking, the same policy was being legislated as had been legislated in 1990, was legislated again in 2002, 2003, and is being legislated again now. So I'm overstating the case, but not in my mind by very much. There are changes that are coming in this bill. There are obviously changes around public health. There are changes around the degree of clinical engagement in commissioning, around the links between commissioning and local communities through health and well-being boards. But these, in my mind, are developments of a consistent policy direction. And it's one of my simple propositions that the direction of policy in terms of the management structures of the National Health Service has been consistent under every single health secretary since Ken Clarke, myself included, with a single exception, and that was Frank Dobson. Between 1997 and I think it was 1999, Frank did go in a somewhat different direction. I don't remember him being regarded as a huge success at the time, but he was undoubtedly an exception. And apart from Frank, in truth, every health secretary since Ken Clarke has, broadly speaking, espoused the same set of intellectual management structural ideas. So I'm more than happy to answer questions upon it, because it's 21 years in, it's a very familiar set of themes. But I want to suggest to you that those aren't the real reforms. They're certainly not the unprecedented reforms that the National Health Service now faces. So let me move on to the second set of reforms that the Health Service faces that are genuinely unprecedented. And those are the ones that are the consequence of what in the Select Committee we refer to as the Nicholson Challenge. The reason we describe it as the Nicholson Challenge is that although there have been various different formulations of it, in truth it is the same challenge as was first articulated by Sir David Nicholson in his annual Chief Executive's report about the Health Service in May 2009. Significantly, 12 months before the general, or significantly anyway to the political class. It was articulated 12 months before the general election. It was endorsed by Andy Burnham as Secretary of State before the general election, and endorsed by Andrew Lansley as the new Secretary of State following the general election. So it's not a matter of party political controversy. The Nicholson Challenge is what will probably be familiar to you as the £20 billion challenge, but which we in the Select Committee tend to articulate in a slightly different way. And let me go for a moment into that. The problem with describing it as a £20 billion challenge is that it invites the question, £20 billion of what? Is this £20 billion of cuts? Well, not really, because the government's committed to much more modest real terms growth, but nonetheless real terms growth in the NHS budget. And if we can eliminate the decimal points, round the numbers, what's in reality committed through the lifetime of this Parliament is a flat real terms budget for the National Health Service. So £20 billion isn't really cuts, but what it is an unprecedented efficiency challenge. And the way I prefer to articulate it is to say the health service during the lifetime of this Parliament has a flat real terms budget, very modest growth in order to preserve the party political position, but in round numbers, flat real terms budget. But of course, somebody said to me quite recently, the change since 2009, the beginning of the Nicholson Challenge, is that the health service is moving into a period of no more. To which my response was, you're half right. No more money, certainly, in real terms. But of course, the demand load on the health service will continue on the long-term trend rate that it's established over 60 plus years. And if you take the trend rate of demand for health care services, demand has risen, and we should assume will continue to rise by, roughly speaking, 4% per annum. And so no more is, as I say, only half right. We have 4% rise in demand going on all through this Parliament, but for planning purposes, no real terms growth in resources. And so the Nicholson Challenge, as I think it properly understood, you don't need an MBA to work out that if you've got flat real terms resources and 4% continuing growth of demand year on year, the only way you meet demand is by achieving 4% efficiency gain 4 years running. And that's my preferred articulation, because I think it's clearer what the implications are of the Nicholson Challenge. If the health service is to meet the demands placed upon it during the lifetime of this Parliament, within the budget that's been allocated by Parliament, the only way of doing that is to deliver 4% efficiency gain 4 years running. And just to set that in context, 2 observations. The first is the National Health Service throughout its history has never delivered 4% efficiency gain in a single year, never mind 4 years running. And as chair of the Select Committee, I've asked every relevant witness that's come before us, do you know of any healthcare system anywhere in the world that has delivered 4% efficiency gain 4 years running? And the answer's no. So I can never prove a negative. So it's a challenge, an interesting intellectual challenge for a Sunday evening. Somebody may be able to find a precedent for 4% efficiency gain 4 years running out of an advanced country healthcare system. But until somebody can, I'm going to continue to work on the assumption that if we deliver 4% efficiency gain 4 years running, we will have done something that is genuinely unprecedented. And so that's why I go back to my original thought. There are two parallel reform programs, one of which is all too precedented, the other of which, if it's achieved, would be a genuinely unprecedented achievement to deliver 4% efficiency gain 4 years running out of an advanced country healthcare system. And in the Select Committee, we've sometimes been reported as less than fulsome in our support for the government's stance on healthcare policy. And the fundamental reason for that is that if you're embarking in one of the largest organizations in the world on the objective of delivering an unprecedented efficiency gain, then it's not a bad idea to focus on the huge task that has been taken on. And let me just add to that, just in case anybody thinks that's comfortable, that's okay, 4% efficiency, I know how I can do that. Let's just remember as well that this is not simply an efficiency objective and an efficiency program, because we all know, don't we, there are too many examples of failures of quality within the system as it is at the moment. We've seen over the last couple of months stories of system failure, in particular around services delivered to elderly people, where the quality of the services we deliver now is not as good, doesn't meet the standards that we would all want to see of the National Health Service. So the Nicholson challenge is to deliver the quality of service we all want to see at the same time as delivering this unprecedented 4% efficiency gain 4 years running. And that's the reform program that interests me, because it's the reform program that impacts on the daily lives of everybody working in the health service, but even more importantly than that, on the experience of the patients who rely upon the health service for the delivery of their health care. How can we deliver 4% efficiency gain 4 years running while improving the delivery of quality objectives that have always been there and will continue to be there? Now, the next thing to say is this all simply a coded way of saying, actually, the job's impossible? And I have to say, I don't believe that's a conclusion we should or we can afford to or should draw from the evidence. I do think when we sit down quietly and look at where this system can be improved and focus on that as the day job, there are huge opportunities to use resources more effectively, to focus on priorities, and to at least make a decent stab at delivering this Nicholson challenge. But the reason I focus on 4% efficiency gain 4 years running, and I don't like the 20 billion formulation, another reason, is that one of the ways I hear the 20 billion formulation described is that somehow, somewhere in the system, you can go around and you can find your 20 billion. There's no part of this system that can be exempt from the Nicholson challenge if we're going to deliver the objectives that I described. It is a system-wide challenge. Every part of it needs to be engaged in the process of delivering the quality and the efficiency objectives that I described. It is a change management program without precedent anywhere in the world. So, having offered you the thought that this is as they say, a modest proposal, I think John Knox once referred to some particularly outlandish proposal as a modest proposal. It's a huge undertaking. It's a monumental undertaking. How do we set about it? Well, the first thing I think we need to do is to look, whenever you're engaged in a change program, is to understand where the opportunities are, where what's the nature of the opportunities we face. The first thing I want to suggest to you is that most people in SW1 when talking about health policy, they have in mind a patient that they think, fondly believe, is the typical patient of the National Health Service. And this individual, very familiar to any of you who've been to policy wonk land about how the health service needs to develop. This patient is a normally healthy adult who walks in to see their GP, is diagnosed as having a condition which is open to treatment. They're referred for treatment, they're treated, they walk out healthy, and they get on with their lives. And in SW1, there is a touching belief that this patient is the typical patient of the National Health Service. Everyone in this room knows that that individual, their needs are real, they need to be met. But I've just described patients that represent, roughly speaking, 10% of the workload of the National Health Service. The other 90%, the core activity of the health service, are people with more complex conditions, usually comorbidities, and the great majority of whom will not, however good the care we provide to them is, will not walk out healthy. And so the first proposition to make is that if we're going to respond effectively to the Nicholson challenge, we have to stop defining health policy according to the needs of the 10% patient load of the health service and focus on a system that is designed specifically, purposefully, to meet the needs of the core patient load of the health service, the people with long-term multiple conditions. Second proposition, if you focus on the needs of those patients, it is simply impossible to see, in my mind anyway, to see how you can deliver a system that responds to the efficiency challenge and, equally importantly, responds to the quality challenge that I've described if we continue to believe that the National Health Service can deliver its obligations to those people independently of the social care system and, equally importantly, of the social housing system. I've already referred to the point that the £20 billion is a system-wide challenge in the NHS, but actually it goes beyond that. It's a system-wide challenge, in my mind, in the health and social care system. I try to avoid most of the time now talking about the healthcare system, and I refer to it as the health and social care system, because if we're talking about the requirements of the core patient groups, patient and service users groups, the people with comorbidities, long-term conditions, and so forth, those are people who rely for part of their care and support on the social care system as well as on the healthcare system. And some of the biggest opportunities, both for quality enhancement and for greater efficiency, rely on delivering properly integrated services between the National Health Service, the social care system, and the social housing system. Integration, of course, is very much the buzzword. It's one of the bits of true value added, I think, that came out of Steve Field's NHS Futures Forum work during the summer of this year, is the heightened commitment right across the system to proper integration, both within the health service and beyond the health service, to include social care and to include social housing. Whenever I talk about integration, I always enter the observation, not entirely flippantly, that if we could get the pharmacy to integrate into the rest of the hospital service, it would be a step forward. But beyond that, it isn't just between health, social care and social housing. It's also within the NHS family itself to get proper integration. We're all familiar with the example of a primary care centre where there's a practice nurse and a community health nurse and a social care nurse operating sometimes almost literally in neighbouring offices with from different budgets, different management responsibilities, competing incentives, and this is where the last element, the last talk was so relevant, different IT systems and no information sharing. So if we come away from the strategy for a second and just look at it from the point of view of the elderly patient trying to find their way around this system, like I'm of an age, and I suspect looking round I'm not unique in this, in having had the experience of an elderly parent who saddened. My wife's father actually passed away earlier this year, a man in his late 90s who was being passed from one part to another of this system. He was, by the time he died, had poor eyesight and even poorer hearing. He was repeatedly asked the same questions. He didn't understand the questions because he couldn't hear them. He gave slightly different information every time he was asked the same questions. It was fed into the IT system of the person asking the questions, who didn't then share it with the rest of the system. So we had a completely disintegrated system, the result of which was not merely huge expense, because every time he answered those questions, somebody was being paid to ask them again, but also poor quality, because the system wasn't integrated in a way that it needs to be if we're going to deliver the kind of quality enhancement and efficiency gain that I started off by talking about. So the challenge facing everyone in this room, myself included, I don't sign myself out of it as a politician, the challenge is to recognize that against the background that we all know of the financial pressures, the Nicholson challenge is 4% efficiency gain 4 years running, delivering improved quality. The way, in my mind, by far the biggest single contribution to that process, and that's not to say there aren't numerous other examples, of course there are, but by far the biggest single contribution to the delivery both of the quality objectives I articulate and of the efficiency objectives that I articulate is to really to achieve a degree of integration in these services, the creation of proper patient pathways across the different silos in the system that uses resources more effectively and delivers, because it's more integrated, a better quality service to the individual patient and service user. It's a huge challenge, but it's a process of change management. And if there are two final points I want to make, which is about how you achieve change management on this scale. 2 points. Firstly, and this one is addressed actually probably not very much to people in this room, more to my colleagues in Westminster. If we're going to achieve change on this scale, there's only one way to do it, and that's to face into the need for change. If we go around reassuring people that at the end of the process the world's going to look much like it did at the beginning of the process, we won't get there. And so when politicians believe that caring for the health service means caring for traditional institutions within the health service, traditional hospitals, traditional patterns of the delivery of care, what they're doing is defending a care model that met the needs and used the technologies of 50 years ago, but is not designed to meet the needs and the priorities of today's and tomorrow's patients. So we need to understand, we need to embrace the fact that if we're going to turn these words into something real, it does require a substantial change in the way care is delivered right across the health and social care system. And to those of my colleagues who wonder what that means or wonder how it's explained to nervous constituents, the answer, a part of the answer, of course, lies in reminding ourselves of the NHS dirty secret, which is that there are departments and sometimes whole institutions that doctors won't refer their own members of their own family to, because they know the truth, and we know truths about the quality of care available in some traditional institutions that are not shared with the general public. That's why availability of information about outcomes, about what goes on in some of our less salubrious, some of the less successful parts of the health service, that's an important part of what needs to happen. We need to explain, we need to face into the need to change and explain why some parts of this system need to change. That's the hard edge. The other thing we need to remember, and it's key in my mind to change management on this scale, is that there has to be a bit of sunshine in it. If you invite people to come with you, whether it's NHS staff or the wider public who care about the health service, and it all sounds like a developing thunderstorm, you can't be surprised if they take a bit of persuasion. The case for changing the system in the way that I describe is that the result is a system that is better focused on the needs of today's patients, uses resources more efficiently, delivers care to a higher standard because it's designed to meet the needs of those patients. So, yes, we have to explain that some things people have grown used to and grown comfortable with will no longer be part of that system. But in addition to that, we also have to set the context of what we're trying to deliver, which is something which will use resources better and deliver, as a result of, partly at least as a result of that, a higher quality of care. That's the real reform program facing the National Health Service.